Hi, this is Brian Kim. I'm going to share with you case number 236 in the Best Way to Do Cataract Surgery series. And the purpose of this title is not to suggest this is the best way, but to get you to think about your best way to do cataract surgery, which means scrutinizing your technique, watching videos, and figuring out, honing your technique, refining your technique so that you can do the very best for your patients. So this is a soft lens. You're going to see very efficient lens disassembly utilizing mechanical fracturing techniques with double chop and cross chop, and then at the end, Hydrus microstent placement for glaucoma. So this is a cotton tip which will steady the eye, and this is a corneal marker which will help me to center and size the rhexis. And I always use a cotton tip to steady the eye throughout these maneuvers. I make my paracentesis incision first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and to flatten the anterior capsule. In this case, the pupil is really dilated after the viscoelastic. And then I forgot to make my incision for the Hydrus, so I go ahead and make my paracentesis incision for the Hydrus. I like to make my incision early because you can get heme. And if you have heme, it's very difficult because you can get interface heme when you put your gonio lens. So it's better to make your Hydrus incision early at the beginning of the case. This is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then when I'm ready, I enter. And these are the micro forceps, sharp tip forceps. I puncture the center, pull down towards me, grab the right side of the tear, going around circumferentially, grabbing and re-grabbing as I go, using the cannula to control the eye throughout this maneuver. By having the cannula there, I have better control, in my opinion, and I try to make that rhexis the same size as the corneal mark that I made earlier. Irrigate the surface of the eye, and then placing the viscoelastic on the corneal surface. Drip a little bit of BSS to make the viscoelastic uniform. And this is the capsule fornix hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, get a nice wave, lift the edge of the lens up, decompress the bag. You can see the lens is already loose, and then the lens begins to spin. You can see it's a really big pupil. And you'll see again, this is a soft lens too. Lifting the incision with a chopper, going in with irrigation off to minimize decimase trauma, removing the surface epinuclear material, placing the chopper under the rhexis edge contra-incisionally, pointing the phaco tip vertically sub-incisionally, bringing the instruments together. You can see how easily the lens is cut. When you have such a soft lens, sculpting the lens makes no sense. Being able to flank the lens with the instruments and then cutting it with mechanical forces is really the most efficient way for a soft lens. Placing the chopper around the right heminucleus, hooking the peripheral lens, pulling it centrally toward the phaco tip. Because both instruments are flanking the lens, I'm able to pull the chopper towards the center and crush the lens against the phaco tip as if the phaco tip is a chopping block. And within seconds, I've cut the lens with double chop and cross chop into 3 pieces. Go ahead and lift that first quadrant up, using some vacuum to emulsify the lens piece, and then separating the second quadrant from the rest of the lens, again performing another cross-chop maneuver, and then emulsifying the lens. Turning that second heminucleus in front of me, crushing the lens in half, and then grabbing each quadrant up with some vacuum and emulsifying the lens pieces. Again, very efficient removal of the endonucleus, and then grabbing the epinucleus from anterior to posterior. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA piece. Peeling the cortex from anterior to posterior. By doing it this way, you get a cleaner removal of the cortex. Nice big pupil, as you can tell. And again, a nice clean peeling of the cortex from anterior to posterior. Hopefully I won't have too many cortical wisps. Switching to polish mode, I see some fine wisps attached to the posterior capsule, polishing under the rexus edge to remove the lens epithelial cells. So again, with soft lenses, it's really my opinion that really chopping techniques are far superior than sculpting. Because remember, purpose of sculpting is to create a groove and then crack. But if the lens material is soft, it won't crack effectively. So I really feel like sculpting is really better for denser lenses and chopping is really better for softer lenses. Just in general, kind of speaking in broad terms, I really think that's true. Pulsing BSS into the subincisional capsule fornix, disengaging the irrigation, and then pushing cohesive viscoelastic to fill the bag. Again, really nice pupil in this case. Sweeping under the rexus edge, first on the left side and then the right side, removing the lens epithelial cells. And since this is a Hydrus, I'm going to push some more viscoelastic to open up the contralateral angle and then put some viscoelastic on the corneal surface. But before doing that, I have to put the lens in. I got a little excited. I went out of order here. And so this is the Li61AO lens. I make sure the barrel of the injector is not rotated. I want to keep it straight up and down. As the leading haptic goes in, it swings from left to right, but it's going to swing right back as the optic comes out, so don't change the position. So you see it's switched right back. The optic is in the bag, the leading haptic is in the bag, and by using the plunger, I was able to get the trailing haptic in the bag as well. So again, so the lens is nice and in, that looks really good. Put some more viscoelastic on the corneal surface and into the angle. Turning the eye away from me, putting more viscoelastic on the surface, placing the Hydrus through my incision that I made at the very beginning of the case. Again, you don't want to have any heme. That's the purpose of making the incision early on. Putting the gonio lens on the eye, getting into focus. And because of the position of my incision, I have a great approach. I stab anterior TM. So go ahead and stab. You want to be able to pierce there. It's very important. And then once I'm pierced, flatten out, advance the Hydrus. And as I'm advancing it, I want to really make sure that it's coming out properly. So that's very important. So I wasn't quite sure if it went in the proper space. So I withdraw, I stab again, and I start to see the heme come out, which is a good sign. Go ahead and advance the Hydrus. Withdraw, and then pushing the notch in. And I feel pretty good about that. You can see here now there's heme coming out of the tip of the Hydrus, which is a good sign that I am in the proper location. Go ahead and reorient the head. Go in with irrigation off. Activate irrigation. Oh, I have a big chunk of lens material that was subincisional. So go ahead and eat that piece. Get underneath the lens, removing all the viscoelastic from within the bag. Reposit the lens back down. Polishing under the rexus edge. Removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a patient with a big pupil, somewhat of a soft lens. You saw a very efficient lens disassembly, essentially flanking the lens with the instruments, not using vacuum, not using ultrasonic energy, just keeping infusion on to keep the eye nice and firm, positioning the instruments around the lens, flanking it, keeping it deep at the same horizontal plane of the lens, endonucleus, bringing the instruments towards the center, basically crushing the lens, and then performing the same maneuver with the cross-chop maneuver, and then again performing the Hydrus. Again, I like to make my Hydrus incisions, all the incisions actually, at the very beginning of the case, because in this case you saw there was a little bit of heme at the very beginning, and this helps reduce the risk and chance for interface heme. You saw a very nice placement of Hydrus, and you saw a heme coming out of the tip. At the very end of the case, you saw nice blanching as well, and that's the end of the case. So again, this is an example of a soft lens utilizing mechanical fracturing, double chop, and cross chop for efficient lens disassembly and Hydrus microstent. So I hope this was helpful to you, and I thank you for your attention.